protocol. Friends, at the very outset, I would like to thank Dr. Prasad and his team for inviting me here. Well, Dr. Prasad actually wanted everyone else to tell a little bit about their journey. I was actually motivated by Dr. Dholakia. And I did his fellowship. He told me, when I met him, he told me that if you want to go a long way, please make a team. He said that his team was always fixed. His assistants, his nurses, even ward boys were fixed. So when I came back, actually I asked one of my colleagues, some of you must be knowing Dr. Jurani, that we joined hands and we started pooling our knowledge. We were not from medical college, so it was difficult for us to gather knowledge. So we started pooling our knowledge, our skills. Each of us went for different fellowship, different courses and started pooling, and that actually helped us in developing. So I would request all my junior colleagues to please make a team first and then go ahead for a long journey. Today I am going to speak on a very important topic, sometimes neglected, post-op management after TKR. One of my professors once said that our specialty is little different from other specialties of surgeries. Because in other specialties, the treatment usually ends with the surgery. Say you remove gallbladder, appendix, treatment is over. Wherein our specialty, treatment begins with the surgery. So if we want to see grateful patient who are satisfied with painless mobile joints, we should give due importance not only to a good surgery, but good post-op care. That's very important. Why our job is challenging? Because we are dealing with old age group who are usually weak physically and mentally, and often they ask this question whether I'll survive the surgery, whether I'll be able to walk or not. So I feel that we must reassure the patient in post-op period and motivate them for rehabilitation. Besides, many of them have comorbidities like cardiopulmonary problem, diabetes, obesity, renal problems. So we should involve the help of other specialists to prevent complications and for optimum results. So what are we aiming for in post-op period? First and foremost is control pain. This is what the patient is most scared of. So please control pain and prevent the complications like excessive blood loss, DVT, infection, and rehabilitate them quickly. So usually, or it's preferable to keep them in surgical ICU for a day of surgery. Because here you can administer some oxygen to them for a few hours. You can put monitors for their vitals. You can actually monitor their input and output, which is very essential in the patient who have cardiopulmonary problem and renal problems. And subsequently, supervised diets can be given. The most important thing in post-op care is pain management. Nowadays, we go for multimodal pain control. So that intra-op we give actually many cocktails, analgesic cocktails in the tissues. Post-operatively, the usual pain control is by epidural catheter. The epidural pump which is attached to it delivers 0.25 or maybe 0.125% of bupivacaine intermittently or slow release as per required by the patient, and gives excellent analgesic effect. Besides, it can be supplemented by some IV injections like paracetamol, diclofenac. It's always preferable to avoid narcotics because they cause a lot of sedation respiratory depression, which is not good, and have many GI complications like vomiting, constipation, etc. etc. We may prefer to give even patches, ketorol patches and other patches. Second most important thing which we have to do is reduce blood loss. Before the advent of this tranexamic acid, there used to be a lot of blood loss. But fortunately, with the advent of this, which we give not only pre-operatively but post-operatively, it reduces the blood loss to the extent that many surgeons have now given up putting drays. Besides that, antibiotics are very important, especially one antibiotic shot 12 hours after the surgery. One pre-op and one 12 hours after the surgery. Second generation cephalosporin. I give cefuroxime and levofloxacin. This is must after 12 hours. However, I give for 1-2 more days because I feel if there is catheter and other intervention, it's better to give them for 1-2 more days. Another important thing is prevention of deep vein thrombosis. Our patients are at great risk. Why? Because during surgery they are paralyzed. There's a lot of stasis of blood. On the top we put a tourniquet which damages the endothelium and also causes stasis. Plus patients are older and have problems of atherosclerosis. So it's very essential that we prevent this complication. The very important thing is mechanical. Most preferable thing is mechanical, which is done with the help of sequential calf pump. This presses sequentially foot, ankle, calf, knee, thigh like this. So it doesn't allow stasis to occur. Second thing which we do nowadays, the aspirin has found to be very effective. So we start aspirin in the dose of 150 milligram BD. It's given for a couple of weeks. However, I reserve, there may be a difference of opinion, I reserve low molecular heparins for very high risk patients, like those who have history of stroke or MI or obese patients or malignancy or something like this. If you give chemoprophylaxis in the form of low molecular weight heparins, please check the wound. There are high chances it may bleed, so keep a watch on the wound. And if necessary, you can give them antiemetics and antacids if they need. On day 1, first thing is, if you put the drain, you remove it along with catheter. Send the blood for CBC and electrolytes. If the hemoglobin is less than 8, then I transfuse them with packed cells. Many times we find patient post-operatively feeling weak and confused. This at times is because of electrolyte imbalance. Please check it and correct it. Then continue the pain management. We start early weight bearing. Sometimes few people do it on the day of surgery. I usually do it next day. But it is started really vigorously along with just physiotherapy, especially for obese patients and those who have pulmonary problems. Day 2, the bulky dressing is removed and a small dressing is put. Now for my junior colleagues, I would like to advise, when you do the dressing, please flex the knee and then put the adhesive. If you put the adhesive in extended position, this will come off when we do physiotherapy. So it's very important you keep the knee maximally flexed. Usually antibiotics go away, also epidural catheter go away, and DVT stockings are given to prevent DVT. And usually now oral medication starts. Also it's very important to give them cold packs of cryotherapy. This helps in reducing inflammation and pain to great extent. Do it many times a day. Vigorous knee exercises in the form of bending, bedside sitting, toilet training is started. Usually by day 3, the patients are fairly comfortable. Many of them can climb the stairs and many of them can walk with the help of a cane. Therefore, usually patient is ready to go home in my setup. Few surgeons, they discharge patient early. I discharge day PO4. I advise them regarding physiotherapy. I give them analgesics in the form of usually Ultracet, and sometimes gabapentin also helps. The prevention of DVT is again important, so continue with the aspirin and stockings and cold packs for pain relief and reducing inflammation. At 2 weeks time, usually the sutures are removed. Patient is encouraged to take more activities in the form of climbing stairs, move with minimal support. Here, I would like to tell you, if the patient doesn't achieve, in very few minuscule patients who have a stiff knee even after 2 weeks, it's better motivate them for mobilizing under GA. This is the right time, 2 weeks to 3 weeks. Mobilize them under GA, and I've done it 1 or 2 cases and it really works. And usually your patients are osteopenic, so always start them with calcium, vitamin D and bisphosphonates. Usually at 6 weeks, I would just call the patient to say hello and take the x-rays, assess the progress. Usually the patient is recovered in 12 weeks. So friends, to summarize it, it's very important that we reassure and motivate the patient in post-op period. Control pain, early mobilization and prevent complications, and believe me friends, a happy post-TKR patient is most grateful patient. I thank you very much for your attention.
All the 3 speakers of the session to please be on the stage. Dr. Rajiv Bhargava, Dr. Anil Oman and Dr. Anil Arora, please be on the stage for question answer session. Dr. Phil Hurst, Dr. Anup Khare, please come on the stage. And any questions for these 3 lectures are invited right now. All the speakers and other respected panelists are there. Okay, boss. Can you hear me?
Hello. I'm Dr. Harish from Lucknow. Any one of you can answer. Thank you.
As he said, the physiotherapy and interferential is very helpful sometimes to remove this arthroplasty. The most important point is the pain relief. And I agree with whatever you said, but I feel it has been often overused term, arthrofibrosis. Pain because of any reason leading to less movement and secondarily leading to ortho. Arthrofibrosis as a primary pathology, yes, I have rarely encountered, especially in those patients who are emotionally unstable, poor pain control, and quite anxious. They will end up.
We can hear you very well.
The knee is nicely balanced, soft tissue ended well.
Hello?
You are happy on them.
Yeah, we can hear you very well. After 2 to 3 questions, I will hand over the...
Sure.
Thank you.
Rajiv, though we come to day-to-day life meeting, what is the criteria of post-operative discharge of the patient? I mean, clinical criteria for the discharge of the patient post-operative.
At times people have comorbidities, there may be a lot of pain. So if patient is really fit, physically and mentally, they may be even discharged early. Because we usually stop IV fluids and vigorous management in 2 days. So maybe he's ready to go third day. However, if patient has comorbidities, have pain, and we find them there, they are not going to mobilize nicely at home. So it's better to keep them for 4-5 days.
Rajiv, actually in our government setup, SMS hospital, as you know, there is a lot of patients are there for the arthroplasty waiting, and everybody wants to stay there. And we want to discharge them as early as possible within 72 hours. Is it possible if he gains the movement of up to 90-degree flexion and no sign of infection, no other sign of any hematoma like that?
Yes, he may be sent early.
Okay, thank you very much.
Okay. But
Okay.
sending a date being bilateral name,
70.
I have not seen patients very comfortable on day 3. In our setup, the protocols are a bit
Sir,
different.
younger patients, comparatively younger age patients are comfort within 72 hours. But the older patients are usually not.
Younger patients you will find will be mainly of inflammatory arthritis,
Exactly.
rarely osteoarthritis, maybe
Yeah.
post-traumatic. And if a patient is of inflammatory arthritis, believe me, they have a lot of pain as compared to osteoarthritic patients. Will kind of agree to this point?
Yes.
I wholly agree with that. Just a tip, in our hospital, every hospital, every practicing surgeon has his own constraints and workplace issues. We have patients coming from very far and we don't take a chance, we discharge them only at 10 days. That might not be the same case elsewhere. But I have a suggestion, especially to people who discharge early, 3 or 4 days also is fine. And younger, like we said, patients on DMRs, rheumatoid, inflammatory need to be restarted on their therapy and preferably usually 7 days post-op. But again, look at the dressing, look at the physiotherapy. It depends on how often you can review the patient in the OPD. Because don't send the patient off and not let him come back probably a week or 2. It's better to see him at least every 2-3 days, especially with you to do his exercises, making sure he's doing his physiotherapy, what is it, just go to sleep, and to have a look at his dressing very frequently, at least for the first 2 weeks. In our scenario, I think that plays a very good role because you don't want to land up with the situation. Make it, and if possible, make sure it's a waterproof dressing because once you send the patient off, you don't know what is happening.
Thank you very much, speakers.
Only one more question because the patient is already in the spinal. The OT is ready. So for just brief about the patient who is going to be operated. The name is Mr. Mahesh Tiwari. The left knee is going to be taken up first.
Hey Vishal, can you hear the voice of Dr. Reddy? Hello? Hello?
We cannot hear you very clearly. Voice is not clear. Hello?
Can you see the image?
Yeah, we can see the image, but we cannot hear you very clearly.
Okay. So Dr. Reddy is talking now. Hello, can you hear me? Can you hear me?